Thank you. It is quite a privilege to be standing up here and speaking to you, and I want to first just make some quick acknowledgments. First to Judge Pechman, of course, who is the leader of this charge in terms of helping us define how to get class members into the most therapeutic settings that they deserve. And that is a guiding light that has, I think, shined over this case and shined over the nation as people have looked at the state of Washington in terms of thinking about these competency issues. So that's somebody that I just absolutely want to acknowledge. Also, the court monitor, Dr. Mosh, who's also a dear friend and colleague in that order, for inviting me to help her in her work and allowing me to be up here today, as well as my friends at Policy Research Associates, who I've been working with for a long time. You got to keep this microphone down, sorry. That keeps bouncing back up. And all the work that they're doing to help across the country to look at justice-involved people who have behavioral health needs. And then, of course, the class members. Dan didn't quite get it right. I've actually worked on the ground in many states. I've worked as a practicing psychiatrist and as a forensic psychiatrist, really at all of the intercept points. I'm not going to show you the slide of me in a bulletproof vest on a police ride-along. I'm not going to show you a picture of me testifying in court on competency issues, but I've worked at really all of the intercept points and understand how much work it is to build diversionary services and the complexity of staff training and getting the right treatment and the right programs for people. And so I just want to acknowledge the hard work that you all are doing and the point of taking some time in these 2 days to really think and enrich your minds and go back and bring creative enthusiasm. I don't know if anybody read their booklet in the hotel room, but in the hotel room there's a little booklet about not making every day as if it's your last day, but making every day as if it's your first day, where you come in with enthusiasm, like you're starting a business, and you're enthusiastic and you put your best foot forward, not like you're burnt out and tired and overwhelmed. And so we have a lot of problems in our systems because we have so many people that feel overwhelmed in an under-resourced system. And it's really important that we just keep putting our best foot forward on every day as we try and do the best for the class members. So I am going to be talking about the competency system new paradigm that is really looking at implementing community competency restoration. And I couldn't agree more with, I won't say Dr. Leifman, although his mother would be proud, he tells me if I said that, Judge Leifman, and his words about restoration and what it means and what it doesn't mean. I'm going to talk about that so that it puts some light on that, but also recognizing that the purpose of my talk is to really talk about community restoration. What would that look like to really integrate community restoration? And really what it means is mapping it onto diversionary services. You know, we really want to think about how do we keep people out of the justice system who don't need to be there in the first place, but then if they are in the justice system and they do have an issue raised that raises constitutional rights and their legal interests matter, then competency and competency restoration can matter. But we don't want to use that as the proxy to having their medical and human needs be overtaken by the legal needs. And so in our psychiatric literature, our forensic literature, there's a lot of debate about, you know, which interests are more important and how do you work in systems where multiple interests are mutually important and keep all those needs met. And so what I like to keep as a kind of a guiding principle for me too is this framework about thinking about, I've been using this analogy everywhere I go, diabetes management. Diabetes is a chronic illness, chronic relapsing. We've learned a lot about illness management and recovery in diabetes. And what we think about is that when somebody has diabetes, they may need supports and treatment wherever they are, even if they're arrested, even if they're in the justice system. You're not going to take them off their insulin just because they have an arrest. It has nothing, one has nothing to do with the other. So if we think about some of the conditions that class members have, and as chronic relapsing recovery possible positions and people living full and meaningful lives included in society, we want to think about what are the natural supports that they need, regardless of the systems that they're in, keeping them out of the systems that they don't need to be in, and helping support their community success. So as has been mentioned, and as you probably know, I want to talk a little bit about the national framework and bring some of my perspectives, having consulted in many, many states and worked on the ground in several states. One of my hats is I'm the chair of the Medical Directors Division for the National Association of State Mental Health Program Directors. And they did a survey of the states back in 2017. Amanda Wick and the NRI group published this study, which essentially, it's hard to see each state, and it was hard to collect the data from each state. But essentially, if you look far over to the right, and if you look at the basic trends, Washington is not alone. You've heard that already. Most states are having challenges in their competency systems, and each state and each community within each state is often coming up with unique solutions to address this challenge. Washington is looked at, and models are taken from Florida and elsewhere, and I'm hoping what you can learn from this talk is a little bit more about what's going on around the country. In addition, when I first got to Michigan I think I got there in 2016 from Massachusetts, we hosted a learning collaborative where we invited our 5 neighboring states. We all talked to each other about the competency system. We did a whole analysis of what are the challenges at the front door, within the restoration services, and then at the back door. We wrote a report related to that, and the forensic division presented that. Since then, SAMHSA has picked up, the Substance Abuse and Mental Health Services Administration, competency as a major issue for states that are dealing with this, and the SAMHSA Gaines Center, which is also through Policy Research Associates, was awarded a grant to help take the model that we did in the Midwest and make it a statewide model, and we did a virtual learning collaborative, and you can see the states that are highlighted that applied to be participants in that. And so I spent the summer with Lisa Callahan and others going around the country doing technical assistance to these various states and hearing from them about what their plans of action were and taking their lessons learned. And so this talk is informed by a lot of the work by a lot of people in many jurisdictions with many rural, urban, and other challenges. So this is the picture that I often present about the current process, the way we work with people that are found incompetent to stand trial. In some ways, I refer to it as the chutes and ladders system. I don't really like that analogy because chutes and ladders is a fun game, and this is not a fun game for the people that are in it. But it is the situation where one can get into the competency system, if you will. One might have the success of being restored, but the risks of recidivism are high, the risks of decompensation and illness are high, and so the chance of flowing back through the system and starting all over again is high. And so what we're seeing is people cycling in and out of various institutions, various systems. And so when you think about that diabetes story that I told you in the beginning, what we see medically is we see disrupted episodes of treatment and disrupted care. And so when you already have people who are vulnerable to transitions, and transitions are hard for all of us, you have even greater challenges. As Judge Leifman pointed out, you've got a traumatized population, you've got numerous challenges with families and friends, as Judge Pechman pointed out, that they've lost along the way. And so you have this whole problem of not having continuity of supports and continuity across the system. So whenever we think about building services, we have to think about the long view. You can divert from one intercept, but if you're not thinking about how this person is going to be supported over the long haul of their lives, if they need that kind of lifetime support for, again, until they no longer need it so that they can live independently and autonomously and function as well as possible in the community, then we're not thinking holistically about the people. And that becomes very challenging because there's funding silos, there's policy silos, there's legislative silos, there's legal issues, there's this case, not the next case or the case before. And so there's a lot of reasons why the system has been built on a one solution to one problem plan. And I think this is why it's exciting to think about the sequential intercept model as an opportunity to think about how people flow through the system and how their needs might be identified and how they can be rerouted into other avenues to receive the services that they need and then hopefully be able to adhere to the services. One of the things that we don't talk a lot about is treatment engagement and retention. This is a big area of focus, and something that I think is really under-discussed is how the treatment system needs to look at engagement over the long haul. And so we see the sequential intercept model. I'm assuming everybody in the room is familiar with this because this is what the diversionary services are built off of. But it looks at the Intercept Opportunities, starting with Intercept 0, the community-based services, and all the way through Intercept 5. So I'm going to walk us through a little bit about this. Intercept 0, looking at what are the crisis lines, the crisis care continuum, and hospital structures, the civil hospital structure, so to speak, that could really retain people, get people connected into the right supports, and help to avoid that criminal justice involvement. One of the problems is we're seeing, and I think the case of Sarah is a really good example, one of the problems we're seeing around the country is that the arrest rates from treatment settings alone create some of the competency issues. So I think the Intercept 0 could even be dialed back a little bit to Intercept -1. I don't know, maybe we should have started at 0.1 and then gone to 0, but we really need to think about how do we train our workforce, not just the police officers in CIT, but how do we train our staff to think about crisis de-escalation? And how do we train our own workforce in community mental health to think about when somebody is justice involved, how to work with them. The good news on that front is there has been some funding opportunities to build off that. I can tell you that SAMHSA has funded something called SMI Advisor, Serious Mental Illness Advisor. I'm fortunate I'm the criminal justice consultant to that. We're building some training modules for the provider workforce on working with people that are justice involved. PRA also was awarded a grant to look at how to inspire psychiatrists to work with the justice involved population. This is going to be a big area of focus, I think, for SAMHSA in terms of thinking about those workforce issues. But it goes beyond just the psychiatrists. It's all the community health workers and the like, who, when a person becomes behaviorally dysregulated, which can happen due to trauma, it can happen due to psychosis, it can happen for any number of reasons. Any one of us could become behaviorally dysregulated. How the system deals with that is a major issue that routes people into the justice system. And so I think there's some opportunities there as you're thinking about your innovations in diversion to think about what is the necessary services and what does the staff training need to be to help, because the default of arresting people from waiting rooms and emergency rooms and inpatient psychiatric units isn't really tenable anymore. And so what does the Intercept 0 look like? We have a crisis care continuum that is expanding and has a lot of potential: mobile crisis outreach, police co-response models, walk-in urgent care, emergency room diversion with peer supports. Peers are a huge potential workforce that we can tap to help with this population, again, with that, to get that retention in services, not just the linkage to services. These various levels of care that are out there, the Crisis Now model, which has become really popular to think about, looking at how does a crisis get dealt with, how does data inform the thinking about crisis services, and then how do people get linked following the crisis, because anyone who's built a crisis center will say a crisis diffuses, and then what? And so you really have to be thinking about that longer approach to how people are working. Critical time intervention is another practice that's been evidence-based and looked at, which really is one of the models that we've used for some of the wraparound support services for one of the models that a colleague and I have been working on at the Justice Interface, which really looks at not just putting in case management and just saying, there you go, but putting it in a thoughtful and planful way, putting in those types of supports, recognizing that in critical time intervention, there's critical times where you need more intensive supports, and then as people gain their footing and their stability, those intensive supports can be relaxed in a measured and thoughtful way as the person is linked to more traditional services. And so looking at those models as rather than just a one and done warm handoff, but in a graduated way of doing a handoff to regular providers. And then we have the Intercept 1, which is, of course, where CIT comes in and training law enforcement, specialized training so that they do better by thinking about people with mental health issues or developmental disabilities. I'm not going to go through all of them, but we mapped on here, and these slides are available to anyone who wants them. We mapped on here some of the fantastic work that's going on in the phases of the diversion programs that are happening already in Washington, and that's an exciting it's exciting to be able to have this many to list. I hope someday there's even more. But you can see that we've got intensive community support, co-response, pre-booking diversion, mobile outreach, and a variety of other types of interventions. Hopefully you're seeing your own programs up here spotlighted. And so diversion at Intercept 0s and 1 is really what first responders do differently and what the treatment providers can do with those first responders to lead to system change and how people work together. This is really a key intercept point when you think about the funnel in the justice system. This is where the most people touch the justice system. It's where there's a lot of opportunity to impact a lot of people. Intercept 2 is the initial detention and initial court hearings, and we've been spending a lot of time thinking about, well, where does the competency system fit in on the sequential intercept model? And Intercept 2 is officially where it would first begin because the competency issue gets raised at the point in time that a person is in court and there's a question about their ability to serve as a criminal defendant. And one of the important things that people have to realize is that what we're looking at in terms of functional abilities is we're only looking at, does this person's cognitive capabilities or mental health symptomatology compromise the tasks that are demanded of them for this charge and this criminal trial, or if it's going to be a trial, or criminal decision-making that has to happen if somebody's going to enter a plea bargain. It does not look at the whole array of capabilities or challenges that the person might have in their life. The competency system has been designed and the competency case law is really looking at, does this defendant have the abilities to go forth in this charge, in this criminal matter? And so the competency flag gets waved, but unfortunately when the competency flag gets waved, all the other things that the person needs often don't get waived and don't get identified, just the competency, at least in the traditional system. And I'm hoping that from this kind of summit, we can think more broadly about that. Intercept 2 diversion generally is a really important area. So when you think about competency being waived, Intercept 2, there's a lot of studies. There were a lot of studies about the school to prison pipeline, a lot of studies in kids. We know a day in detention puts youth at more risk for being criminal justice involved as adults. We are learning the same thing about adults. A day in detention for an adult can potentially put them, and this Kentucky study showed, puts them at more risk for criminal recidivism down the road. So this is also true for people with mental illness who happen to have issues that make them more challenged. And the irony is that when you think about it, the people in the competency system are the probably, well, they would be, if they're found incompetent to stand trial, the most mental health or disability challenged group in the justice system. They are the most vulnerable in the justice system. Yet ironically, the competency systems have evolved, making them the least eligible for diversion. Because once the competency flag is waved, people get routed into that slide I showed you before. They get routed into the justice system, and everybody, probably mostly, I'd like to believe, for the right intentions because of the legal posture. The defense believes they're getting treatment. The prosecution believes there's public safety is addressed. The judge believes that the issue of competency, which is a huge constitutional issue, is addressed. And so for probably all the right legal reasons, people have long held the belief that the competency system has solved the problem for that person, but that's the reason why we're here today, is we're seeing that that's not, in fact, the case, and yet we have people who are spending days in detention, often in unfavorable conditions, as Judge Leifman pointed out, and and at risk. So this Intercept 2 diversion is going to be a really important point. And my point to this slide and making a big issue of it is to say that you can use diversion even after the competency flag has been waived. There's no reason that these individuals should be ineligible for diversion just because the competency issue has been waived. So the essential elements include identification and screening, looking at whether there's court-based connected clinicians who can be at the ready to evaluate them, recovery-based engagements, and then proportional responses, as we heard, and we've heard over and over. Oftentimes people are arrested on either misdemeanors or nonviolent felonies where there's really no interest in further pursuing the case, and so we're getting to hold people in detention without really any real plan to further the prosecution at the end of the line. So Intercept 2 becomes an important place. And again, you have great things happening in the state of Washington at Intercept 2, and that's exciting as well, both at initial detention and at first court appearance. So competency issues also can come up at any point in Intercept 3, because as you all know, once people are held, even if they look competent at one moment, when they come back to court, their competency issues may appear again, because mental illness is not static. People, even with developmental disabilities, may not be recognized early on. They may be recognized later as cases unfold, and so the competency issues can get raised even at Intercept 3. We know that in Intercept 3, we have jails and courts that play the critical role, and we were just having a sidebar conversation after Judge Leifman's talk about what are the services that are being offered within the jails, and we don't want to ignore the fact that that person with a chronic illness needs treatment during those services, even during a period of detention, but oftentimes those services are lacking, and the connection to community services is lacking, and so the opportunity for diversion becomes less. Court options, post-booking diversion, and the like also exist at Intercept 3. We see treatment courts and dispositional courts, and again, working in the jails. We see in Washington a lot of screening going on to try and link people, reentry services and the like, to try and link people to some community disposition that offers them an opportunity to be moved out of the jail institutional care and into community-based services. So what are some gaps at Intercept 2 and 3 for defendants found incompetent to stand trial? Number one is the idea that, again, once the competency issue is raised, there's often a limited options for anything that looks like community-based restoration. And the tradition of using state hospitals, what we're seeing around the country, is really trying to turn a ship that has existed for a very long time, where everybody believes that the hospital-based care is the only option and the best option. And certainly in Washington with the alternative sites, there's been an effort to look beyond the state hospitals. But what I am asking for people to look at today is to think about what is the continuum of care that's necessary for people with mental illness generally, and can that continuum of care be available for people also within the competency system? And obviously we have to think about public safety, and I'm going to talk a little bit about that as I go. So there's been, for people who are found incompetent to stand trial, there's been the one-stop shop of a restoration service, usually within the confines of a locked setting. And so how do we think about moving and planning, building partnerships and project teams, clarifying purpose and mission, looking at the target population, identifying what a model could look like, look at the data collection that's necessary, mechanisms to review the data, means of improving programs from data review, and continually educating key stakeholders that there are potentially other alternatives that are available. So that's where we have to think about who's our target population, who are our class members, what are their behavioral health needs. Well, serious mental illness is obviously one. This is just a limited list. This is kind of buckets, big buckets. There's obviously nuances for every individual. There's co-occurring conditions. But we have, in the big bucket, serious mental illness. We have people with intellectual and developmental disabilities, people with traumatic brain injury, people with dementia and neurocognitive conditions. It's interesting, I'm involved in another project looking at some some issues with several geriatric neurologists and geriatric psychiatrists looking at the older adult population. And we just looked at our Michigan data and found that about 1% of the people that are coming through our competency system and opined are over the age of 75 and we're still looking at kind of new charges or not, and about 4% are over the age of 65. And so this is an interesting, small but critical population to think about, the older adults, and how are they going to be served in terms of what we do. And again, the state hospital system, which was really, I mean, back in the day, it was designed for everybody that wasn't in the almshouse, I guess, but we're not there anymore. We have other services, and we're more sophisticated in terms of how we treat all these different conditions and how we think about them. But again, once you're in the competency system, you're not eligible as much. Oftentimes, for example, somebody who would be better served in, say, a nursing home placement isn't going to be eligible because of the charges, and so perhaps their neurocognitive decline isn't going to be well addressed. And I can tell you some sad stories that I've dealt with where we essentially have people in the state hospital who die in the state hospital because that's the only place they can be because of their charges in the criminal system. So we're looking at actually this group I'm working with is looking at, are there options just like we have for the juvenile system to dismiss charges for older adults in a, sort of thinking about how we're looking at older adult inmates and compassionate release issues. So I won't go too far down that rabbit hole, but it's been an interesting one to think about recently. What also do they have as personal needs? Well, having spoken to many class members and many defendants in my career, and many people who have been in the competency system or have had a history of being in the forensic mental health system, they have a lot of needs: food security needs, personal safety needs, housing needs, benefits, community supports, whether it's rehabilitation services, mental health services, substance use disorder assistance, family connections. Some are people with military histories who have needs within with veteran support needs, and again, some are older adults, and the list could go on and on and on, but again, that's not generally what's looked at. There's also this issue of stigma that I think cannot be overlooked and must be stated up front. I did a community mental health conference last year, and I asked people to tell me what they thought about when they heard the word forensic. And nobody thought of a pleasant thing. Nobody thought of anything nice. They thought of murder, they thought of violence. Some of them thought of Quincy, the old show of the forensic pathologist. I mean, when you ask people the litmus test, when you say somebody's in the forensic system, you don't have warm and fuzzy thoughts. And so one of the problems we see, and I can tell you from my own experience in trying to build the Veterans Diversion Project, we had people who had had years of decorated military service, then had some mental illness, they fell out of favor in the military, they may have been dishonorably discharged, they may have still been entitled, some others may have been entitled to VA benefits, but we had acute psychiatric units in the VA system who were declining their care because now they were being referred from the courts and they were labeled, even though they didn't have a forensic tag, and I know the VA system doesn't generally take people that are found not guilty, in the competency system or in the not guilty by reason of insanity system. But the point that I'm trying to say is that when I've tried to build programs in the community, when you say you're sending people from the court, or when you say you're sending people from jail, or when you say you're sending people from the forensic system, even if the persons being served are the very same people that this system would have served, once you put that label on them, there's this assumption that they're much more violent, they're much more risky, and they're much more scary, and they won't be able to be managed, or quote-unquote managed. And so one of the documents that the Council of State Governments put out, which I think is really useful, is for judges and legal professionals and others on the overvaluation of risk amongst persons with mental illness. I've seen many programs where they use, even if they're using an evidence-based risk assessment screening tool, where they use the option for override if somebody's identified as having mental illness, where they label somebody as more violent because of the concerns, and it comes from probably a paternalistic or maternalistic thought that people need more supports and supervision, but what we see is as people get more criminal justice supervision, they're more likely to get technical violations and non-technical violations, because people are going to see when problems arise in a way that they wouldn't have otherwise seen. So the question for where do competency restoration services fit in the community really requires a very thoughtful analysis of what is the risk of this individual for public safety and what are their needs from their mental health and developmental disabilities perspective. And I think we have to be very careful about what we're calling high risk, because when we think about it, it may be that they're facing a felony charge, a nonviolent felony charge. It may be that they're facing a minor charge. They may have historical factors that present risk. They may have current factors that look risky but aren't risky. And so there's been a lot of criticism recently about some of the risk tools that overvalue the risk and that maybe disadvantage people with mental illness and developmental disabilities even more because, for example, failure to appear, if they can't get transportation to a court hearing, they may flag on a failure to appear, but that doesn't mean that they're at greater risk to public safety. So we really want to think about where can we put community, who would be eligible for community-based restoration services, and what I would say is what we have to map on is what's their treatment level of care in terms of what's quote-unquote medically necessary for that within that continuum of care, and then really who really needs to be held in detention, who really needs to be held in jail from a public safety perspective, and then look at those together. And anyone who doesn't need to be held in jail should be in a community-based program, and the community-based program should meet the level of treatment needs that they have in an ideal world. So thinking about changing the paradigm to appropriate jail diversion and appropriate diversion from institution-based programs. We should, again, and I think this was already stated by Sean Murphy, that we want to get people into the right program at the right time for the right reason, knowing that their health needs may shift over time and even their risk needs may shift over time. We have to focus on their needs as well as public safety. So this isn't about anything that would compromise public safety. This is about being smart about public safety. And so, again, remembering that historically and traditionally the restoration goals are to help the defendant get back into trial. They're not about addressing all these other needs that they might have. And so we have to make sure that as we're building these systems in less restrictive settings, that we're looking at what is the full array of needs that they have, again, to reduce the recidivism. So there's a paper that was produced by the National Association of State Mental Health Program Directors that I was part of writing, this Beyond Beds paper that talked about the vital role of the psychiatric continuum of care. And it's really about mapping on, again, these services so that if you have a defendant who might need a hospital level of care, they might only need it for a short period of time. I think that's what the Forensic Assessment Center is that Judge Leifman mentioned, I'll talk about in a minute, that keeps people in the hospital while they need hospitalization, but it doesn't keep them in the hospital for the entire duration of a restoration program. It may seem like a disconnect, like how can somebody with a delusional disorder not need a hospital if their delusional disorder makes them so impaired that they're incompetent to stand trial. But in fact, people walk around in the community setting all the time with a chronic delusional disorder. They don't all need to be in a hospital. They may need help with that task demand for trial purposes, with helping them learn what they need to learn and help navigate the legal system, the criminal legal system, but it doesn't necessarily mean they need hospital for the entire duration of that program. So we really have to think about this continuum of care and plan for stability, plan for moments of crisis, because people do need that backup plan, and plan for shifts as their levels of needs shift. So that's how we think about, how we should be thinking about expanding on Intercept 2 and 3 diversion programs. So what's the mission? I think every program needs a mission and a vision. I mean, this is a little bit long. It kept getting longer and longer, so maybe it's not the ideal mission. It's not so pithy. Maybe I have that same problem that Dr. Mosh said. But it's really about promoting healthy people and healthy and safe communities. I think that's really ultimately the mission of what we're trying to do here. And reduce recidivism, prevent deeper penetration into the justice system for basically the class members, while thinking about competence to stand trial and providing early identification and redirection to coordinated community-based treatments with appropriate supports, community supervision if needed for public safety, as well as services to promote their restoration to competence so they can resolve their criminal cases. And that is an important issue because an open case is also hard for somebody because they don't know whether they'll be turning left or turning right. It's hard to make a disposition plan when you have an open case. So there is an ethics to restoration in and of itself and why the treatment system needs to tackle this in a way that the hospital systems have done. So again, one of the challenges has become that restoration is not always clearly defined. What do we mean by restoration? But the way I think about it is unpacking the elements. So if you're going to build a community restoration service on top of your diversion program, what are those elements? How do you unpack the elements? Well, again, it's treatment as usual, habilitation supports that they need at the proper level within the proper setting. Potentially some linkage to court so the court can be apprised of whether the competency issue has been resolved. And then the restoration-specific elements, which traditionally have included this legal education curriculum. And, you know, a legal education curriculum, I think, probably could benefit a lot of defendants, not just those that are incompetent to stand trial. It is something that a lot of the systems have rested upon. One of the things that has always troubled me is that we're looking at capacity. We don't want the legal education curriculum to be the thing that, you know, that drives all, because, and certainly, you know, these are individuals who have mental health and cognitive challenges, who've probably had difficulty passing tests in classrooms, and we don't want liberty interests necessarily to be dependent on whether they can pass a test or not. We really want to look at, from a competency perspective, whether the functional impairments impact the task demand necessary for this criminal case, and how do those evolve as we work towards educating people and helping them resolve their own criminal case with their defense attorney or even as a pro se defendant. And so there have been some specific approaches to specific populations. For example, the Slater method out of Rhode Island has some literature attached to it about how it works with people with intellectual and developmental disabilities. There are some that has been used in a community-based setting. This would be, for example, in terms of mapping on an outpatient competency restoration program, how a program flow chart might look, identifying the eligible participants, identifying whether the parties are agreeable, thinking about the eligibility screening, having the court hearing so the judge is aware that they've been diverted. And so this is just an example, and it might not work in this jurisdiction, but it might work in others, of thinking about what would be the necessary component parts, how do you weave in those forensic evaluations to see whether the competency issue has been resolved, and then the disposition of the case. In another study done through NRI, Amanda Wick did a survey of across the country of states that are using outpatient-based competency restoration. This is available online. There's approximately 18 states that are establishing competency restoration in their communities. We're working on this in Michigan. Michigan's not flagged, but we're looking at that right now. 35 state statutes allow for it, so we really have room to go in terms of having communities build these services. And then within states, there might be county variation and variation of availability and design. In a study done by Dr. Goensmith, that was published in 2016, as well as in the Groundswell report that was produced in the Trueblood case, there were some findings that were put together in terms of what are some common elements for these programs. First of all, that many of them are new and just evolving, or new-ish. The size of the programs vary from being very small to having more than 100 participants. I was just doing some technical assistance in a particular state where they had, I think it was, they had identified maybe 24 defendants that were going to be misdemeanant and non-violent felons in this entire year across the state, and even that seemed to overwhelm the system, and it was across the entire state and across multiple counties. So we're talking about, to me, this is sort of just partly the education, because we're not talking about huge numbers of people for each county to look at because we're talking about, for outpatient competency restoration, we're only talking about those individuals who have been adjudicated incompetent to stand trial and therefore ordered for restoration, who don't need hospital level of care, and are deemed to be safe to be in their community. So we're talking about a narrow group of the class members that hopefully will get wider as diversion programs evolve. But if you divert before they're in the competency system, none of those people would need to be in outpatient competency services anyway. So what we're trying to do, and I think what this summit is trying to do, and what's happening around the country, is really looking at, again, getting upstream, minimizing the numbers of people that are in the competency system to begin with, and then building out where you can the services in less restrictive settings as much as possible for those that need it. So for any county, you'd look at your own numbers to see what that means, but from the studies, there's ranges in terms of the numbers of people that are served. Some of them are under court supervision. Most operate with participants as part of their pretrial defendants under some kind of pretrial services. And so if something goes awry, they can come back to the court and maybe ultimately, as they're restored, serve and stand trial or plea bargain or get a disposition on their criminal case, and otherwise have the charges dismissed at the end of the period if they're not restorable. The charges usually are for misdemeanors and nonviolent felonies, although there are efforts to bump that up, and we've learned a lot even in mental health courts about bumping up who can be included in these community-based programs without compromising public safety. Demographics tend to be more males than females, minorities more seen in the urban populations, and the common clinical factors, about 2/3 have mental illness and about 1/3 have developmental disabilities. Often they're labeled as having stable mental status, they're willing to take their medications voluntarily, and they have substance use needs. So those were some common themes. The admission processes can be anything from step downs from a state hospital where it's no longer necessary to have them on an inpatient level of care. So that could be one source of referral. It could be that they come from an acute hospital, like Judge Leifman had modeled, and that they're initiated. They could also be initiated straight from the court, from the community, identifying them, and it could be a court order specific type of service. In terms of the location and the support elements that are, if you unpack what people are actually getting, when we did our learning collaborative, one state talked about their competency restoration program involved a case manager diverting people out of the justice system altogether and ultimately just tracking people pre-trial, and then charges would get resolved at the end of the day. Anyway, they really weren't doing restoration, the legal education part of it at all, and that's an interesting thing to think about. And so what we see when Amanda Wick looked at the data across the country, outpatient levels of services, residential rehabilitation centers in a couple places, again, psychiatric acute inpatient, not state hospital, like in the Miami Forensic Alternative Center, and I had the privilege of going out there in the spring. Essentially, those individuals, they are deemed to meet medical necessity criteria. They bill for their services. When they no longer meet medical necessity criteria for inpatient, whether they're restored or not, if that delusion still impacts their understanding of the judge's role in the trial, they still can be discharged to community-based services, and the restoration can continue, but they can get those community supports. So that's important to think about, again, what the level of care is. The funding issues for these programs, when they are getting treatment, and the reason why I think it's very important to unpack the services is because treatment as usual that people generally get has funding sources attached to it. And that's an important piece to remember. And that brings up the whole issue of outcomes. And what do we know about restoration programming and outcomes? I'll just say that the outcomes on restoration programming are very complex. Kirk Heilbrunn and Patty Griffin just wrote a paper that looked at some of this even more in depth. And one thing to realize is that there has never been a study that's looked at this legal education curriculum compared to treatment as usual without a legal education curriculum, or this legal education curriculum compared to that legal education curriculum, or fidelity, and I've developed a wraparound support model where we do a lot of fidelity monitoring. When you do cognitive behavioral therapy, you're supposed to do fidelity to the model. There's never been a study that's looked at the fidelity to the training program, the curriculum, and across programs to see whether fidelity matters, how it's delivered matters, dosing matters. And so there's also complexity in terms of restoration timeframes. Restoration timeframes Some studies will tell you what the timeframes actually mean. Some studies, you don't know whether you're talking about the restoration opinion timeframe or the court adjudication. And sometimes the opinion comes in, but the adjudication takes 3 more weeks. So now you've looked at restoration programming across a time frame that doesn't really look at the time it took to deliver that service. So I would just say that when we look at the research on restoration, it's got a lot of methodological spots in it and holes. And so we don't really know for sure what it all means. Again, it's hard to imagine that some legal education can't be helpful to all defendants who are going through some process and they want to know what their rights are. I mean, that's something that lawyers spend time talking to their clients about, but we don't really know fully. So it's not. This is just something to take note of. The outpatient restoration data generally looks at misdemeanors and, again, low-level felony charges. And so, again, we're only looking at a subset of the population in terms of the rates of restoration. Usually, so we're looking at a subpopulation in terms of what percentage gets restored. And the rates, if you look across studies, 35% to 95%. Well, you could say, well, wow, that program that had 35% restoration rates, what a terrible program. But you don't know if that program was looking at a particular group of people with particular issues. For example, were they more people with intellectual and developmental disabilities who are less likely to achieve the capacities relevant to restoration? The average was about 70% restorable and 20% unrestorable. And there was some data that suggested slightly more unrestorable in outpatient programs. But again, that could be because these are people that are served in the that have chronic illnesses. Their cognitive capacities are not necessarily going to improve, where there's a lot of research on medications and cognitive capacities. And they may only get to a certain level of cognitive ability in terms of abstract reasoning and judgment that's necessary in a competency task, but it doesn't mean that they're unsafe to live in the community or to be living and having some work and employment and relationships and the things that they need. So again, you have to look at what's the population, the time frame. The data suggests Texas reported 70 days, but on average it was about 149 days to restoration. But again, that data to me is a little bit fraught because the clock starts ticking at a certain point, and how it's measured may be jurisdiction dependent. If you are collecting your own data, the best you can do is try and look at, is your jurisdiction doing better than you were before with your program? And so other data available looks at negative outcomes, and I say that with caution because that phrase negative outcomes scares everybody. But if you really look at the data, the negative outcomes weren't violence. The negative outcomes were psychiatric decompensation, people having issues with their mental health. And we know that we can treat people with the best of medications, and they, again, like with diabetes, you may have relapses in the illness. Sometimes people go off their medications, that is absolutely true, but sometimes people have relapses even while on medications. So one of the negative outcomes that was measured was mental health decompensation and then rule violations. The important thing on that was that there were low, even with those being the defined negative outcomes, which did include arrests and elopements. I don't want to minimize that there were arrests and elopements, but even if you look at arrest data, that's complicated why people got arrested. It goes back to the CIT issues and whatnot. Even with all those negative outcomes, for outpatient competency restoration, they were low levels. 16% had negative outcomes during that period, and none were considered serious. Most, again, were acute psychiatric decompensation, which then would warrant potentially a brief hospitalization, but not necessarily a return to jail or return to a long-term state hospitalization. We should, how would we treat that person if they weren't in the competency system should be one of the things that could be thought about. So the management strategies depended on the issue. Hospitalization became one management strategy, reconsideration of the treatment plan, reconvening of the stakeholders to reassess whether the outpatient competency restoration was going to happen, and in some cases, charges ultimately were getting dismissed potentially anyway. And in the Groundswell report, Dr. Goen-Smith wrote, in short, there is no one right way to operationalize outpatient competency restoration programs, nor has one model been shown empirically to yield better outcomes than others. They are a relatively new phenomenon, and most programs have little outcome data suitable for analysis. So who's suitable for outpatient restoration, given that we're really kind of building a bridge as we walk on it without a lot of the data? And again, hopefully even, Washington will be one of the states where data will continue to be produced. The clinical needs, again, would allow for the outpatient level of care. Risk, community risk issues from a prosecutorial perspective and failure to appear issues might require resolution to allow for that community-based alternative. That's the bail issue, the bail bond issue that's people are looking at, where people with serious mental illness, unfortunately, are further disadvantaged because of their track records of appearances often lead to some disadvantage. And then a clear understanding of who's providing services and for whom and what services are being provided. It's also important to think about medication management. I know we have at least one other psychiatrist in the room, but the medication management issues are really a challenge. People do look different in different settings. People get frustrated that diagnoses shift across settings. Formularies are different across settings, so people will have their medications changed for a lot of reasons that makes it complicated. So the more we can think about whatever services, that there's somebody that's helping pass information forward and maintain some continuity, the better. We can do better with treatment of what we call positive and negative symptoms of schizophrenia, mania, depression, impulsivity, cognitive symptoms. We can do better with thoughtful psychopharmacology. There's a whole literature on the underutilization of clozapine, for example, in the United States compared to European countries. Lots going on in that area. People with serious mental illness are often not getting the medication-assisted treatments they need for some of their substance use disorders. And so then there's these other issues to consider. Once they're restored, how do we maintain the restoration? Same issues apply, continuity. I've talked about the formulary differences. How do we look at, even amongst evaluators that are looking at restoration, inter-evaluator reliability, what frequency is necessary, because oftentimes people won't be reevaluated for a period of time for a variety of reasons. So they could end up in the competency system already having been restored just by receiving regular treatment. And so then we have to also think about what happens with the unrestorable defendant who may get transitioned into the civil system but may still be at risk for coming back into the criminal system. So I just want to point out what's already been stated. There's a study out of Arizona that looks at if you take defendants who are in the competency system, and this was an interesting study, they matched, and I don't remember exactly the case scenarios, but say, for example, I'm in an argument with my mother, I happen to have schizophrenia, the police have an option, they take me to the emergency room or they take me to jail. In this study out of Arizona, out of 293 admissions for defendants that were deemed unrestorable, matched against those that went into the civil system, they were fewer met admission criteria, even though they were admitted to the state hospital for restoration. More received court-ordered treatment as opposed to voluntary treatment, and they had longer hospital stays despite being found less dangerous to themselves or others than the community sample. So it goes back to that story of stigma. It's a really interesting article to think about. We also have to think about the services at the reentry point, because we do have people that are held in jail that still will be. We obviously want to minimize that, but thinking about how to ensure that there's good reentry services for the people in the competency system, and that's why it's exciting to think about the Forensic Navigator program coming up. And if they are under pretrial terms of supervision, what is that going to look like? So we have some great examples of how that's unfolding in the state of Washington, but we want to think about that. Again, at the reentry level, matching the needs for the individual and then thinking about where can continuity of care come in. This is a paper that's actually going to be it's going to be put out for public on Friday at the National Association of State Mental Health Program Directors. This was a paper I was asked to write, which was a really cool experience. They asked me to look at international practices around various things related to mental health. And one of the things that was really interesting is looking at this issue of how across the world we're seeing this principle of equivalence, which is an idea that, again, people should have the care they need in whatever setting they're in, and in the National Health Service, for example, and I know we have all this complexity about our funding, just making sure that people have continuity of care, and we have this right to treatment within our U.S. Incarceration system. These are big Intercept 3 and 4 areas about making sure that we have good care while people are incarcerated. Some interesting data out of Michigan. We have a mental health diversion council. I sit on that, and we have an evaluator who's been producing some tremendous data for us. Very interesting. In many communities, the jail health services are contracted out. What our data shows is that where you have actual community services reaching in and building, continuing those engagement strategies, we have far less recidivism than where you have no touch of the community system. And it gets to that reentry, InReach, community care. And so we have actual data to show better outcomes for when there is that InReach. And a lot of times the jail health services aren't assigned to pay attention to what's happening in the community. So the community needs to do the InReach for that. So again, just another thing to think about is this notion of perceived coercion. If we are talking about people under court supervision, the importance of understanding what perceived coercion is, that even if somebody's under court supervision, say in a pretrial service for outpatient competency restoration, it's really important to understand the literature that talks about fairness and justice, providing information, not just walking past people as if they don't need to know what's going on with their own lives and their own case, that more people who are mandated to treatment will not feel as mandated to treatment if they were treated fairly and if there's that treatment alliance. And that this is where I feel like there's a lot of cross-training that needs to happen and a lot of bridge building, because we do have an overtaxed behavioral health system and under-resourced, and there is a lot of challenge in working within those systems with burnout and whatnot. And we don't want the traumatized, the patients, the people that we're serving are traumatized. The staff as well often feel traumatized in other ways and through other reasons. And so we really need to nurture the staff, build training opportunities, build opportunities to sit and think, as opposed to just running through many, many cases in a day and really thinking about what we're doing. In times of transition, again, I just want to emphasize, need a gentle touch. They need collaboration, and that's why I think it's so exciting that you're all here to collaborate together, to think about what you can do. It's more than just getting the restoration job done. It's really seeing what are the needs, what are the supports that people need, and thinking about the front and back door of coordination through collaboration. So I think I'll stop there. I think my time's out anyway. And thank you for your attention.